A 58-year-old man presents with high-grade fever, throbbing left-sided headache, vision loss, and left orbital pain. He says that his symptoms started acutely 2 days ago with painful left-sided mid-facial swelling and a rash, which progressively worsened. Today, he woke up with complete vision loss in his left eye. His past medical history is significant for type 2 diabetes, diagnosed 5 years ago. He was started on an oral hypoglycemic agent. He discontinued after a year. His temperature is 102, blood pressure 120/80, pulse rate 120, respiratory rate 20. On examination, this purulent discharge from the left eye, swelling of his left half of the face, including the orbit. Oral examination reveals extensive necrosis of the palate with black necrotic eschar and purulent discharge. Ophthalmic examination is significant for left-sided ptosis, proptosis, and an absence of a pupillary light reflex. Lab findings show a blood glucose of 388, a WBC count of 19,000. Fungal elements are found on KOH mount of the discharge. So which of these statements describes the organism responsible for the patient's condition? Okay, so I think you all got the diagnosis right. I'm pretty sure you did. This was a patient with uncontrolled diabetes presenting with orbital findings, swelling of one side of the face. So mucormycosis is our diagnosis. So let's see the histopath. Histopath examination will show non-septate branching hyphae. Okay, and this patient had signs and symptoms suggestive of mucormycosis, high fever, vision loss, periorbital swelling, purulent discharge, likely related to the chronic uncontrolled diabetes with hyperglycemia. It is also seen in immunocompromised individuals or those taking chronic corticosteroids. So that is another important risk factor to associate with mucormycosis infection. Chronic corticosteroids is another important risk factor, but DKA or uncontrolled diabetes would be the one to remember. Mucormycosis, opportunistic fungal infection caused by fungi of the class Zygomycetes. Most common forms are Rhizopus, Rhizomucor, Absidia. These are ubiquitous fungi. They survive on dead decaying vegetations and diverse organic matter. So mucormycosis, depending on the site of occurrence, can be rhinocerebral, pulmonary, cutaneous, GI disseminated. The one to remember is rhinocerebral. That is what our patient is presenting with. So the most common mode of transmission is through inhalation of spores from the air. Patients with hematologic malignancies most commonly develop pulmonary mucormycosis. Rhinocerebral is seen in patients with uncontrolled diabetes. Okay, so just keep that in mind. Although not seen in this patient, the increased risk of iron from ferritin, the increased release of iron from ferritin stimulates the growth of fungus in patients with DKA. So this is not a very high yield point to remember. Just remember the association between DKA and rhinocerebral mucormycosis. Typical presenting features: facial pain, orbital and periorbital cellulitis, sinusitis, facial swelling. And this will progress to systemic symptoms like severe headache, variable grades of fever, mental obtundation. When the infection spreads to the oral and nasal cavity, it can progress from an erythematous lesion with or without edema, followed by violaceous lesions, and ultimately to the development of a black necrotic eschar. So you don't need to know all the stages of development, just know the facial pain, orbital, periorbital cellulitis, sinusitis, facial swelling. So I would remember these, and you need to know that it finally develops to the black necrotic eschar. So these would be the high yield points. Everything in between is not very specific. Okay, so this is a result of thrombosed blood vessels due to fungal growth, which further leads to tissue necrosis. Common complications are ophthalmoplegia, orbital infection, and cavernous sinus thrombosis. Okay, and imaging findings include thickening of the sinus mucosa or extraocular muscles, which is regarded as an early sign suggestive of the disease. Soft tissue involvement is well defined on the MRI scan, and an initial microscopic examination may reveal broad, irregularly branched hyphae with rare septations. Culture can be negative, but biopsy will provide a definitive diagnosis. The treatment is prompt initiation of antifungal therapy. Surgical debridement is very important here, and control of the underlying triggering event. So we need to control this patient's diabetes. So pretty straightforward question. the history was not very misleading. All you needed to do was to be able to identify the histopathological findings. And all you need to know for mucormycosis is the relation between diabetes, rhinocerebral mucormycosis, the facial pain or vital swelling, cellulitis, the black ash scar that forms, and surgical debridement would be an important part in the management.
Thanks for watching. Please give a thumbs up and subscribe for more.